Welcome back. In this lecture, we're going to explore the intricacies of metabolic syndrome and type 2 diabetes. And give you an example of the severity of this illness. I had a man who came into clinic to see me, and he was referred by his physician because his blood sugars were really high and he had uncontrolled diabetes. And we were sitting there visiting a little bit, and in addition to being a dietitian, I'm a diabetes educator. And he said, well, the doctor said you're going to give me a diet to follow and an exercise program. And I had the forethought to say, I wonder if anybody's ever checked this man's feet. So I asked him to take off his shoes. And actually what he had was gangrene of his baby toe. And had I recommended an exercise program for him, I would have made his condition worse. Because this is such a complex set of disorders, metabolic syndrome and type 2 diabetes, we have to be really vigilant in our understanding as well as management. As Americans, we've seen an explosion in our girth, and this is partly due to our affluent society. Metabolic syndrome and type 2 diabetes are consequences of the way we eat and the way we manage our exercise programs. Many people believe metabolic syndrome is actually not a disease, but it's a clustering of risk factors. The risk factors for metabolic syndrome include an increase in blood sugar, maybe not high enough to have diabetes, undesirable changes in blood fats that we've explored in other lectures, most notably an increase in triglycerides and a decrease in HDL, an increase in blood pressure, and the accumulation of what's called visceral or belly fat. And we've explored ways that you can figure out your own risk. So other people will say, you know what, it's not really disease, so what is it? Many people believe it's our early warning system, our radar system, that type 2 diabetes is on the way. And certainly the Centers for Disease Control cite the third National Nutrition, Health and Examination Survey, sometimes abbreviated NHANES, and that says that the estimates in the United States are about 47 million Americans have metabolic syndrome. So it's not an occasional person. This is really a public health epidemic. Also, according to the CDC, they estimate that 24 million Americans have type 2 diabetes, and many experts believe this is really underdiagnosed. So this lecture is going to look at the tidal wave that we have that these diseases represent, and the prevention and the treatment of these all too common disorders. Okay, what are the causes of metabolic syndrome? Well, like everything else, we can be genetically predisposed. We certainly know that individuals who have that central obesity, that pear shape, the apple shape that they have can really influence the development, or maybe it's an early warning sign. And again, in your guidebook, we have ways of you calculating that. The fat cells in abdominal or visceral fat behave badly. They don't behave like other body fat, and they actually increase the level of inflammation in the body. In the Jupiter study that we've referred to in the past, we know that individuals that have an inflammatory response, even if their LDL cholesterol, their bad cholesterol is in a normal range, are at an increased risk of heart disease. So these badly behaving fat cells that increase inflammation really do have a significant disease risk associated with them. Excessive insulin resistance. Well, we've talked about insulin in the past, but how do you know if you have insulin resistance? First and foremost, you can look at where your body fat is stored. Secondly, you can look for something called acanthosis nigricans. And what this actually is excessive pigment where the skin bends, okay, where the skin can fold back. So you can see it on knuckles. Most commonly, you see it around the neck. You can see it under breast tissue, under fat folds, and it's a hyperpigmentation. It's not a hygiene issue. Actually looks like ring around the collar. So you see this hyperpigmented area around the neck. Had a young lady who came into clinic. She had metabolic syndrome. She had acanthosis nigricans. And you know what? She thought, I'm just not cleaning myself well enough. She actually took a Brillo pad to her neck and tried to scrub off the pigment. It's pigment. It's not dirt. And why do we end up with this hyperpigmented area? Well, insulin, that wonderful anabolic hormone, insulin stimulates the melanocytes, the pigment-producing cells, to make more color. So certainly if you're a person of color, if you're African American or Hispanic, it really looks like a dark or black ring around the collar. In lighter skinned individuals, it can almost look like a brown discoloration, most predominantly on the back of your neck. So are there any other things that we should be concerned about in terms of this metabolic syndrome? What else is going to cause it? Well, certainly inactivity. And again, that's a recurrent theme. Bodies are designed to move. So the American College of Sports Medicine, in its wisdom, has come up with a campaign called Exercise is Medicine. They want every physician in the United States to be comfortable in terms of writing an exercise prescription. Estimates vary, but most experts will say that the effects of exercise, the beneficial effects of exercise in the prevention and management of metabolic syndrome and type 2 diabetes last between 19 and 24 hours. So what that means is you need exercise every day if you either A, have metabolic syndrome or type 2 diabetes, or if you're at risk. Inactivity in itself makes the cells more resistant to the effects of insulin. So again, remember, the body has to crank out more and more and more of this wonderful anabolic hormone. And again, too much of a good thing in this case is not a good thing. Okay, how do we prevent metabolic syndrome? Key themes. You got to have a moderation of your weight. This is an example where you must exercise every single day. I want you to think about that as important as taking high blood pressure medication, as important as taking your statin resin if you have high cholesterol, or any other medication that you're prescribed. I want you to start to reframe the way you think. Exercise is as effective as medication, so I must take it every day. Choose this wonderful anti-inflammatory diet. Certainly the Mediterranean diet, which has a lot of vegetables, monounsaturated fats, nuts, seeds, olive oil, all are important. Don't ever step over the need to control calories. Calories are really important. And as we explored in the lecture on carbohydrate, the value of choosing carbohydrates based on their glycemic index. And again, whole grains being rich in magnesium are all pretty essential. Type 2 diabetes. It is the most common form of diabetes. And again, estimates vary, but between 80 and 90% of diabetes is this type. What is type 2 diabetes exactly? Well, it can be diagnosed by your physician, and there are diagnostic criteria. In this case, the body makes insulin, but it's not being effectively used by the body. So it's not an insulin deficiency here, at least in the early stages. It's not insulin deficiency. It's inappropriate use of insulin by the body. This is diagnosed by having a fasting blood sugar, you've had nothing to eat, of greater than 126 milligrams per deciliter, or an oral glucose tolerance test of greater than 200. But like with most metabolic parameters over the last 20 years, we've seen numbers drop. When I first started in practice, diabetes wasn't diagnosed until you had a fasting blood sugar of greater than 140. So stay tuned, you're going to see these targets probably decrease in the next 5 or 6 years. Other factors that can raise blood sugar are oftentimes not accounted for. We don't think about them. First and foremost, medications can raise blood sugar, and they can actually interfere with an appropriate diagnosis. Some high blood pressure medications can cause your blood sugar to be high. Niacin for high cholesterol. This is one of the reasons why you don't want to take niacin unless a physician knows you're taking it. Steroids, and that could be steroids that you're using to control an illness. If you're taking estrogen or testosterone, your blood sugars can be higher. And an anti-seizure medication, Dilantin, can also raise blood sugar. So there's lots of other factors that can complicate or give an inappropriate diagnosis. So you can imagine if you're taking niacin on your own and you're at risk of developing diabetes, and now you go in and your blood sugar's high, you're going to get an inappropriate diagnosis that was actually medication induced. Illness will raise your blood sugar. Fever raises your blood sugar. So what that means is independent of food, physical stress, not the emotional stress of a challenging job, but physical stress or an insult to the body can raise blood sugar independent of food. Well, a lot of people refer to type 2 diabetes as adult onset, and what I hear more often in my clinical practice, it's not a problem, I've just got a little bit of sugar. I'm going to try and raise the bar on that and get you to think about it in a different way. Although we think of type 2 diabetes or adult onset as less dangerous, it's actually now being increasingly more common in children. And again, estimates are going to vary here, but the complications of diabetes are estimated to occur 10 to 15 years after diagnosis. So I want you to think about that when we explore children and type 2 diabetes. Historically, the type of diabetes that we've seen in children is type 1. This type of diabetes is insulin requiring. They must have insulin to survive. However, recent estimates from the CDC suggest that type 2 diabetes now accounts for between 8 and 46%, big range there, of all new cases of diabetes. And part of the difference in the ranges was how old was that study? What was the target at the time? Was it 140 for a fasting blood sugar, 126? But again, I think the most important take-home message is many experts now believe that prevalence is underestimated. Part of that is the signs and symptoms of diabetes are not things that are going to get your immediate attention. Well, certainly we know in type 2 diabetes, is it in your genes? And again, the recurrent theme is absolutely. Twin studies give us the best look at the genetics of diabetes. If you're an identical twin, you share an identical gene pool. If one twin gets diabetes, the chance that the other twin gets diabetes is 3 out of 4. So you have a significantly greater risk. So we now have identified multiple different genes, loci on genes that will suggest that yes, there are some higher risk individuals. However, the environment must be conducive to the development of type 2 diabetes. So estimates vary using CDC data, but the Pima Indians are an ethnic group with a prevalence of diabetes that's estimated to be about 50 out of 1,000 subjects, relatively high prevalence. Ethnically, Pima Indians rarely marry outside of their genetic gene pool, so they tend to preserve their gene pool. A great example is diabetes in the Rio Grande Valley. Diabetes in the Rio Grande Valley, one of the highest prevalence in the United States is down in the Rio Grande Valley, down in Starr County. And part of that is the influence of the Pima Indian gene pool. So we know we have a really high genetic component here in type 2 diabetes. Again, the Human Genome Project has identified over 17 genetic loci strongly associated with type 2 diabetes. The marker on the gene. So does the environment contribute to diabetes? The clear answer is yes, that jury is in. Genetics can be against you, but I want you to think about, I've got this genetic susceptibility, but I do have the ability to control my environment and prevent it. I usually say we're all going to get something, and if I know genetically I'm set up for diabetes, now I can, again, get myself loaded. I can get myself ready to go. I can bring out all my tools to prevent diabetes. But the great news for us is there have been some major prevention studies that indicate lifestyle changes, even in the face of genetic susceptibility, can prevent diabetes. Probably the most predominant one is something called the Diabetes Prevention Program. They assigned people, participants, with blood sugars that were just below the level of prediabetes to one of 3 groups. Placebo, kind of standard care. Metformin, which is a medication that is used to control diabetes, or lifestyle intervention. The lifestyle intervention included 2.5 hours per week of physical activity. So I'm going to say overall that's not going to be a huge amount of activity, and a healthier, low-fat, low-calorie diet. Also, this intervention was actually delivered by registered dietitians, and so there was some education as well. Lifestyle intervention, and to me this is the aha moment. Lifestyle intervention reduced the incidence of diabetes by 58%. Where traditional pharmacology that is used for the same kind of circumstances reduced it by 31%. So it's not that it was reduced to nothing, but lifestyle ruled the day. The weight reduction in the lifestyle intervention group as initial weight loss was 7%. After almost 3 years of follow-up, the total weight loss was about 5%. So they did regain weight, but they still had a significant reduction in the development of type 2 diabetes. So a key message here is even if you can't lose a substantial amount of weight, any weight loss matters. If you have a family history of diabetes, if you have metabolic syndrome, this is the really great news. Okay, other dietary factors. Diabetes control is more than just controlling calories. The type of fat can influence diabetes in genetically susceptible individuals. Studies such as the National Nurses Study, which is also going to be mentioned in the lecture on heart disease, was a long-term study taking a look at a large number of subjects, and that gives science the best look at long-term risk factors. Those who had the highest trans fat intake had a much greater risk of developing diabetes than those who had a lower intake. So again, there's a possible link between trans fats and inflammation. So again, think of that Jupiter study. Also, those who had the highest intake of polyunsaturated fats, omega-6 and omega-3, had a decreased risk of developing diabetes. So the type of fat matters. Okay? However, when we look at poor intake of omega-3 fatty acids, when you don't have a good balance between those two major types of essential fatty acids, poor intake of omega-3 fatty acids have been linked with insulin resistance. So keep in mind you want a nice balance. The amount and type of carbohydrate can influence the development of disease. Diets rich in whole grains and cereal fiber have been shown to reduce the incidence of diabetes. Okay, what's our case for fiber? Those soluble gumming fibers make food leave your stomach slowly, and you get a slow postprandial or after meal rise in blood sugar. So your body doesn't have to work as hard, it doesn't have to produce as much insulin to metabolize those sugars. Okay? Magnesium, that's found in whole grains. Some research suggests that magnesium may be the missing link between whole grains and diabetes. So could it be that it's really the magnesium content that's lost in the processing of the food that really helps to protect our bodies from the development of type 2 diabetes? Certain studies have shown that increasing the intake of whole grains can decrease the risk of diabetes by 40%. Now, I also want you to think about that for just a second. That simple switch of buying a different type of bread or a different type of breakfast cereal, particularly if you're genetically behind the 8 ball, this is a really great strategy. Other protective compounds include the glycemic index. Certainly, if you review the lecture on carbohydrates, we know that individuals that have a high glycemic index diet can actually increase the workload of the beta cell. And the beta cell is part of the body that makes insulin. This eventually can contribute to beta cell fatigue. The beta cells just can't keep up with that environmental demand. Okay? Is there anything else? Well, the answer is absolutely yes. Iron. We know, or we've heard of the word antioxidant, and we think of antioxidants as being good things. Iron is an oxidant. Iron may actually worsen insulin resistance and type 2 diabetes. Now, I have to tell you, there's not a real clear answer here. Is it the iron or is it the meat? In the Iowa Women's Health Study, a relationship emerged between heme iron, now this special kind of iron is only found in meat, and an increasing risk of diabetes. So again, I want to remind you, when we talk about controlling the portion sizes of meat like we did in the DASH diet, there is a reason beyond hypertension, and there may be a link between heme iron found in meat and diabetes. The association was stronger in this study in those who consumed alcohol. Okay? Iron overload is actually thought to contribute to damage to the beta cells. And I have to tell you, in my world of professional football, I see many athletes who have iron overload because we have so many fortified foods. Certainly, we also know that the type of meat, particularly if it's processed with sodium nitrate, may also contribute to the damage to the beta cells. So again, plants tend to rule the day, and in this case, excess amounts of meat, highly processed meat, those with sodium nitrate, can actually damage the beta cell. Eating meats with nitrates almost every day, and where do those come from? Well, think bacon, think ham, think bologna, had a greater than 40% chance of developing diabetes. Okay, so dose is everything. Now, most of us don't think of dose when we talk about meat, but I'm going to suggest to you that the American diet has more animal protein than it needs, and here's a good reason to try vegetarian. Certainly in the Women's Health Initiative, there's been found to be a relationship between vitamin D and the development of diabetes. Part of the problem was they didn't really find a protective effect with vitamin D, and the problem was the dose probably wasn't high enough. A lot of estimates are out there now that our current recommended amount of 400 international units is not enough to keep blood levels normal. Other studies suggest that yes, vitamin D in a higher dose is protective against the development of both type 2 and type 1 diabetes. Vitamin D in and of itself is anti-inflammatory, and it reduces insulin resistance. Now here's a hard part though. If I am over fat, vitamin D is actually sequestered or stored in body fat, making it less biologically available. So I'm consuming the vitamin D, it gets stuck in my body fat, and it's not available to the blood. Now, the beta cell itself, that insulin-secreting cell in your pancreas, is a direct consumer of vitamin D, and it can convert it to its most active form. So again, the beta cell really relies on vitamin D. Okay, what about beverages and diabetes? Coffee. Now again, you're not hearing caffeine here, nor are you hearing energy drinks, but we're talking again about a whole food. Coffee, both decaf and regular, are associated with a decrease in diabetes. Again, this dose-related phenomena, increasing consumption from 1 cup to 3 cups, provides some additional risk reduction. A review of the coffee consumption, great review, was in the Journal of American Medical Association in 2005, and it concluded that regular coffee consumption can substantially reduce the risk of type 2 diabetes. So now when someone questions how much coffee that you're drinking, you can be relatively smug and say, I'm on my type 2 diabetes prevention program. Coffee is a very rich source of antioxidants and actually outperformed tea, which really had no effect. So again, another great reason to have that sugar-free, non-fat decaf latte. Getting some vitamin D, you're getting some calcium, and again, you're getting those rich antioxidants. What about alcohol? The Physicians' Health Study indicated for those consuming light to moderate amounts of alcohol, which we've defined, there was a subsequent decrease in the incidence of diabetes. And it may, again, not be the alcohol per se, but the antioxidants that are found in alcohol. Alcohol can actually reduce the production of glucose by the liver. But if you have diabetes or you're taking medications for diabetes, always check with your physician to see whether or not alcohol is going to be part of your diet. So now let's think about this. What about sugared drinks? Well, now we got a double whammy here. Beverages don't promote satiety or fullness like solids do. High glycemic index foods, which include juices, are probably something that you want to avoid. This includes soft drinks, sweet tea, lemonade, and fruit punch. Now, as we switch gears and talk about type 2 diabetes in children, I'm going to tell you this is a relatively new, and for me, as both a clinical dietitian and a diabetes educator, it's relatively disturbing to me. This is directly related to the increasing levels of obesity in children. Now again, I work in Houston. We have a very high Hispanic population, and we know African Americans and Hispanics have that genetic predisposition. But it's been estimated that close to 600,000 youth in the United States have some degree of glucose intolerance. And the incidence of type 2 diabetes has significantly increased in the last 15 years. Well, since I've been a dietitian for 30 years, I have to tell you, in my first employment at Tulane Medical Center in New Orleans, never saw a child with type 2 diabetes. Now at Texas Children's, our diabetes clinic sees more children with type 2 diabetes than type 1. Our youngest patient is 4. So I'm going to remind you to think the complications of type 2 diabetes start to occur 10 to 15 years after the diagnosis. So that means for our youngest patient, what does that mean for her? The complications are going to occur for her in her teens or her 20s. What kind of complications do we see? Well, we see this general classification of what I call apathies, a disease state. Neuropathy, issues with the nerves, retinopathy, eye, nephropathy, kidney. So remember my man who had the gangrene in his toe? You might have been thinking, why didn't he feel that? Why didn't he have pain? He had significant neuropathy where he couldn't feel his feet. So he didn't know he had gangrene. He had enough abdominal fat where he couldn't see his toes. So a strategy always is, if you have type 2 diabetes, please, please, please check your feet. Because again, if I can't feel the pain, I've lost that ability to have my early warning system. What about the economic cost of diabetes? Can we afford it? From a population standpoint, can we afford it? According to the American Diabetes Association, the cost of care for those with diabetes in 2007 was 2.3 times higher than for those without diabetes. So as we all struggle with controlling healthcare costs, it would be wonderful if we actually paid for prevention. We don't pay for prevention usually in this country. And so what we're ended up doing is paying for it on the backside. As type 2 diabetes becomes a predominant type of diabetes in youth, we can expect to incur greater costs. Well, remember, there's another type of diabetes. What about type 1 diabetes? It's similar in the fact that blood sugars are high, but it's different. In type 1 diabetes, that individual ends up producing no insulin. Their beta cells are not functioning any longer. They are going to be obligated to take insulin for the rest of their life. Most people believe it's an autoimmune disorder, and certainly there are things called diabetes seasons where you actually see more diabetes being diagnosed in the winter month, cold and flu, than other times during the year. But it's represented by the ultimate destruction of the beta cell. So the cells of your body that make insulin can't make insulin anymore. Individuals that have type 1 diabetes are on insulin for the rest of their life. At this point, there's no other option. Certainly in the future, we'll look at stem cell transplants, beta cell transplants, and ways of seeing if we can control or correct type 1 diabetes. These patients are usually lean and usually young. Now, we certainly do know that many people can develop type 1 diabetes really any time in your life. And so you got to kind of be on the lookout. Usually in people who are developing type 1 diabetes, because they've lost their anabolic hormone, they lose weight very quickly at the early stages of their diagnosis. Now, is there going to be a best case scenario for people with metabolic syndrome or type 2 diabetes? I'm going to suggest to you the answer is yes. The reason is, if indeed type 2 diabetes is, you know what, I'm resistant to my own insulin. Insulin's an anabolic hormone. It promotes the deposition of body fat. What's the biggest trigger? What's the foot on the gas pedal for insulin secretion? The foot on the gas pedal is carbohydrate. Carbohydrate stimulates insulin production more than protein and certainly more than fat. So this would be an example of taking a lot of the great public health guidelines saying, anywhere between 45 and 65% of your diet should be carbohydrate. This is where you'd modify it. If the biggest gas on the pedal is carbohydrate, this might be an individual that I'll take the carbohydrate lower than 45%. I've actually taken it down to as low as 30% in individuals that I just couldn't get the metabolic parameters to fall into place. So I'm going to say reducing carbohydrate in individuals with metabolic syndrome, type 2 diabetes, really is a good management strategy. Not zero carbohydrate, but reduced carbohydrate. You can also understand that the type of carbohydrate would need to be low glycemic, whole grain, in getting carbohydrates from healthy choices and not necessarily the processed carbohydrates. Another question I get all the time, other than these pigment changes, are there any other symptoms of insulin resistance? And the answer is yeah. It's that belly fat. It's that big belly that you see that we've all seen. Hopefully none of us have that, but just in case, that big belly that we've all seen, that again is an outward sign as not only are you storing body fat, but that type of body fat doesn't behave itself. It's a more inflammatory body fat, and again, inflammation and insulin resistance go hand in hand. Another unbelievably common question is, does sugar cause diabetes? And the answer really is no. It doesn't cause diabetes unless it's contributing to obesity. So sugar in and of itself in a lean individual is not going to cause type 2 diabetes. Sugar does not cause type 1 diabetes. Type 1 diabetes is an autoimmune disorder. And so there should be no guilt. Oh my goodness, I drank sodas when I was 10 and that's the reason why I've got type 2 diabetes. That's not true. I've heard there are herbal therapies that can be used to treat diabetes. And this answer is actually a yes and a no. There is some science to suggest that actual cinnamon can help to lower blood sugar. The problem is, if I take cinnamon as a supplement, we have no true standards for the purity, safety, and efficacy of dietary supplements in the United States. Tragic in many instances. So I can go to the science and say, yep, there are science studies out there that suggest cinnamon is an effective strategy. The question is, what brand am I going to recommend? If you're going to take it as a pill, is there a brand that I can guarantee? And the answer, unfortunately, is no. But if you like cinnamon in your sugar-free oatmeal in the morning, and you really like cinnamon added to different foods, by all means. The challenge is when you're talking about herbal therapies to treat diabetes or any chronic illness, it's generally more of the herb than you would ever naturally get in your diet. So the challenge is, I can't get this and like my food, so the reality is many herbal therapies are going to fall a little short. Now, is there a cure? because everybody wants a cure. I will tell you that I don't think you can say cure. Your insurance company's not going to say cure. Your physician might not even say cure. But I think from the diabetes prevention study, I think what we can learn is that if I can control all the comorbidities, if I can control the hypertension and all the things that lead to poor outcome, I would consider that a cure. I'm going to consider that a cure. And I've seen individuals whose blood sugars have normalized, their lipids have normalized, and their blood pressure has normalized by losing weight and exercising and following some of the other dietary recommendations. So again, in the medical world, they probably wouldn't call that a cure. In the nutritional world, I'm going to tell you I would. Another question, will the DASH diet help to prevent metabolic syndrome, or is it only meant to treat high blood pressure? How do I combine all these dietary recommendations? And I think that's the bigger question. So does a diet from the American Cancer Society, the DASH diet, the diet from the American Diabetes Association, are they all that different? And the answer really is no. They share some common themes. You're always going to hear controlling weight. You're always going to hear exercise. But the key is, can we tweak it a little bit for our individuals with metabolic syndrome? And again, my strategy is I'll reduce the carbohydrate probably lower than the DASH diet would recommend, because I'm trying to treat all of that. That would be a really good time to go see a registered dietitian so they could assess your own risks and come up with the best plan for you. So thank you very much.